Okay, I've been asked to talk about my favorite smoking, multi-purpose, do-it-all, everything but the kitchen sink ripping Archwire. All right? This is what it's about. Let's start off with, if there's anything I've learned in the last few years about orthodontics, it's just that you want to increase the number of options that you have in orthodontics. You will always be looking for new options. You don't want to stay in one same place. You want to be looking around. Actually, it's kind of humorous to me that this is an Archwire that's been around for a long time, even before I started to work with it in TMA. It's an Archwire that's in one form or another has been around for about 50 years. A lot of people really don't even, to this day, if I talk to them about an asymmetrical keyloop Archwire, they're not sure what it's used for and how it's used. What we wanted to share this afternoon or this morning a little bit about how we use it and how the wire is fabricated, and we got a few of them here, and we'll hand a few of them out, let you work with them a little bit and sort of play with them. Then we'll go through a case and show how we would use that particular Archwire, how we'd select it, and more than that, more importantly, not only that, once we've finished with the Archwire, how do we take the case and bring it home? How do we take this overcorrected overbite, nice buccal segment, class 1 occlusion, and bring it back to a perfect, beautiful overall occlusion? I started with the Archwire, literally 30 years ago. It was an Archwire that was developed by a couple of guys out of Texas named Brard. This is called a Brard loop. Actually, I got it from Don Hilgers, and we used to call it a Snoopy loop, like Snoopy. The purpose of the loop essentially was this. In order to finish, and this is something that, again, when I talk to orthodontists about this at times, I'll say, of course, that in order to have a perfectly overcorrected buccal segment occlusion and appropriate closure of the anteriors, you have to have a step up between your upper canines and your upper centrals and lateral incisors. And they look at me like, a step up? Why would you need a step up? Well, you do. And you need it some in more cases than in others, but you typically need a step up in order to get to that point. That's not your final occlusion. That's not where you're going to leave it. You're going to bring it home from there. But in order to have that function of having proper torque control and overbite control, you need to have a step up at that particular time in treatment. The way the Brard loop worked is simply this, is that he created a step up. And in an 18 slot, we did this out of 1622 stainless steel wire. So there was a step up. The way it worked is that you would bring this down and engage it in the incisors. The effect would extrude the buccal segments and intrude the anterior segments as we close space. It wasn't a very effective Archwire because it was made out of stainless steel, so as we'd activate it, we'd lose some of the activation in the loop itself. And I used this for years in conjunction with a lot of other bioprogressive mechanics. We altered it a little bit. I actually made it out of 16 square wire, and we switched it from the Snoopy loop to the Mickey Mouse loop. And all we did is cross the T's so it was a little bit more effective. And again, the same thing is that if I'm in this particular position, where do you go? How do you close the space? What are your options? See, you come to this particular point in treatment. Obviously, you're not going to close the space unless you get rid of or clear the brackets or clear the incisors down below. So what are your options? For me, they were always, you could put in a utility arch and intrude the teeth and then retract them. You could build a real complex utility arch that intruded the teeth and retracted them. You can put in a reverse curve and let it open and then put in a closing arch. That's 2 Archwires. You could put on a high pull headgear and intrude the upper incisors. This is assuming that the lower arch is level. Or we could put in a Brard loop, a modified Brard loop, to intrude the incisors and close the space while maintaining this buccal segment interdigitation. The reason you have to have the step up is that if you try to close the space without getting rid of this interference, you're either going to jam the lower arch back, jam the mandible back, or as you close the space, these aren't going to go back, these are going to come forward. Obviously, this is a pretty exaggerated case. This has got a lot of anchorage in it, but in many cases, what happens in your space closure is these don't go back, this comes forward, and you lose your class 2 correction. Then, as technology came along and we started to use different kinds of wires, we started to use this same idea in TMA. So about 8 or 10 years ago, we started to develop an Archwire. It's called an asymmetrical keyloop Archwire. This is the wire that I typically use is a 1622 TMA. Asymmetrical key in that it has a short mesial snout and a long distal snout. And it allows you to do the same activations as you saw with the Brard loop. Now it comes as a preformed arch now, but for years I built it out of out of TMA, out of this 1622 TMA. What's wonderful about TMA, this is an Archwire that has gone through its whole use process. It has retracted and intruded the teeth and been taken out of the mouth. I just pulled it out of the mouth and put it down on a plate and we took a picture of it. What's great about TMA is that in deference to stainless steel is that whatever you put into it, by and large, it's going to work itself out. If I say this is going to be the step up, that's what's going to occur in the case. So when we took it out, you're not losing any of the activity at all. TMA is an amazing wire. To make this loop fairly small, we actually bent it around a cone. We bent it around an optical plier. So we bent it around a cone, and you'd go in at 0 degree torque, and you'd come out at 0 degree torque. Very, fantastic wire in that sense. The activation itself, and I'm going to let some of you try this here in a minute. The activation itself looks something like this. When I get into the mouth clinically, I'll take a look at the incisors and I'll see how much we need to intrude them in order to be able to retract them. If it's a millimeter step up, I put a millimeter in. If it's 4 or 5 millimeters, we actually build that into the Archwire. The activation comes by virtue of closing this anterior portion of the loop, so pinching this closed and opening the distal portion of the loop. So what we're going to end up with is the desired amount of step up in the arch by virtue of opening and closing these two portions of the loop. So when we come out of it, it looks like this: closed, opened, the step up that's been built into the TMA. The TMA is going to work itself out, and the beauty of it is that it can be maintained in a real small, comfortable loop. Right? It doesn't have to be a large, cumbersome loop. A couple of other features about the Archwire itself is that because it's not an Archwire that's going to be in the long term, this is going to be an Archwire that's going to be in the mouth for 2 months, 3 months at most, and then we're going to come out of it to finish the case. So what we want to do is we want to put a lot of distal rotation in the upper arch. The reason for that is as we activate the Archwire, the tendency for any closing Archwire that we're going to activate with a cinch back is to bring the upper molars back into mesial rotation. We want to counteract that with a TMA. So when people look at this Archwire, they say, my gosh, it's really contoured in. The purpose is to keep this upper arch broad and to keep the upper molars in rotation as we activate it. This little outward bend you see right here, we commonly put into it just before we place the Archwire. What's the purpose of that? To get it into the tube, to be able to get it into the tube. So we're going to take this, we're going to recurve it backward, nurse it into the tube, then bring it all the way back and activate it, and of course this is then going to be clipped off. So it's bent back outward again with a little contouring plier. It also has a very exaggerated reverse curve of speed. Purpose is extruding, intruding, and then torquing and retracting. Multi-purpose Archwire. So much talk about friction nowadays. It's a great wire for reduction of friction because you're moving segments of teeth rather than trying to move teeth en masse by sliding a wire through your tubes. So this is the little Archwire that we made, and again, I used it in TMA when it first came out for a number of years, and then kindly Ormco was willing to fabricate it for us. And that's the Archwire that looks like what it looks like when it goes in. One thing you also want to do is that you want to have this arch, the loops themselves beveled slightly inward, okay, so that they're not straight up and down. When the arch is preformed, that's something they really can't do. So just before we put the Archwire in, this one hasn't been activated in terms of the steps, we'll take this little loop and we'll bend it inward slightly, then go on the back side of the loop and bend it back out so that we go in at 0 degree torque and come out at 0 degree torque, and yet we have this slight inward cant of the loop itself. The Archwire also has at placement, it looks something like this. Again, we need to intrude slightly in order to be able to retract. We can't just try to close a space. Something negative is going to occur. It's wonderful with ceramic brackets because where we've had problems with fracture, you can put the Archwire in, and then you can do all the torquing that you want to do after the brackets, after the Archwire is completely placed. But the idea is we engage the brackets. We're going to lift this up and place it into the buccal segment. That will then close the loop and bring it back to its normal form. And then we cinch it back by opening the loop or in terms of closing the space, lifting and retracting. The movement is very rapid. I mean, you can close space as you would with any closing loop Archwire, but the intrusion itself or extrusion of the buccal segments, I mean, it's 2 to 3 millimeters a month. It's very, very rapid bite opening. So it's very common. I mean, if you're you want to clear the brackets, this is like 1 month. This is the type of, typically expect it's going to work itself out. But again, this is the type of thing that we're looking for. This isn't where we're going to leave the case. This isn't the finish. This is a transition point to allow this space closure, to allow the buccal segments to seat, and now we're going to come back and bring this case home. The torquing control, in terms of, there are a couple of activations that can be made intraorally in order to place torque on it, and we'll do this with this Archwire when we get through it. The first one is that if you go with a little optical plier at the base of the loop itself and pinch it, it puts what we call gabling torque in it. See the torque in it? It's not a pure torque. It's a torque that as you it'll torque the incisors, but it will gable them also. It'll give curvature to them. Again, you're going to bring this out, but with that little pinch here and over here, you put about 40 degrees of torque in it. So if you're already at 21 degrees of torque, and then you add that little pinch, you've added about 50 to 60 degrees of torque to the upper incisors immediately. See? Very effective in that manner. Look at the loop, though. What happens when you do that to the loop? It opens the loop. So you can no longer retract with this loop. You can torque very effectively, but you can no longer retract with it. Where would that be effective? Think of Class 2 Division 2. Not to close space, but to open, to torque and advance and open, almost like a utility arch. You see? It's your initial wire rather than your finishing arch wire. So very effective in that type of situation. The other way to place torque, the same torque, is intraorally. Instead of pinching the top of the loop, we go in with the same optical plier, and we make this same pinch in the vertical step in the anterior portion of the loop itself. Just pinch it right here. The other side, you can still activate for space closure. And yet we've put the same amount of gabling torque in the upper incisors. And this is just something I'm looking at clinically. I'm not trying to measure it, or I'm just looking at, say, we're a little vertical, we need to intrude, we need to retract, and we need more torque. We just look at it clinically and place those bends in the Archwire. So a lot of times, this is a little 17 square TMA. This is just a Division 2 that we're trying to clear the lower arch. We'll use it open, advance the upper incisors, torque the upper incisors. 17 square TMA, by the way, has more torque control, has a better slot fit than or as good as a 1622. Very, very active torque control in a 17 square TMA Archwire. Let's take, I show this case not because it's a difficult case, but this is the garden variety Class 2 Division 1. The kind of mechanics that I'm going to show going through this case are very rapid, obviously, but what's nice about it is that this is about 50% of your practice. They're not real severe Class 2s, they're not severe facial, they're not orthopedic problems. This little gal's at Class 2 Division 1, real pretty, deep bite. Idea is to correct the Class 2, retract the buccal segments, level the lower arch, intrude and torque the upper incisors, retract them, and then reseat them. That's your segment of mechanics. It's a little more severe than it looks in the photographs. If you look at the models, it's maybe a 3 millimeter, 4 millimeter Class 2. Typical cases that we see all day long every day. Maybe 3 millimeters, 2-3 millimeters of overjet. This is an appliance that I use in a lot of Division 2s. It's a little distalizer that expands the upper arch and distalizes the molars. I only use it in Division 2s because the whole anchorage is coming from the teeth. We're going to bracket up all the teeth, and we're going to advance the upper arch at the same time we're distalizing the upper molars. So we don't put any Nance button in there. It's a real clean little appliance. This is the appliance itself. Oftentimes I'll band the upper bicuspids for a little bit more stability. This is a rest that's going to be bonded on the upper second bicuspid on the distal aspect of it. This is an 027 TMA distalizing spring, and it's attached on the bottom side of this Hyrax appliance. I think this is a Forestident. I've used Forestidents and I've used Leonis. They're you can weld a sheath on the other side. And you can see that there's a solder point here so that the whole appliance goes in mesh. You put it in at one time. You shoot like you would a rigid, Hyrax appliance. We activate it first, go ahead and get all of our expansion of the upper arch that we need to in terms of the Class 2 correction. This isn't correcting a crossbite. This is just taking care of the arch form asymmetries between the upper and lower in Class 2. So we do all the activation first, and then I just go in and sever this with a high-speed burr, release the upper molars. Let them go back 4 or 5 millimeters, and then stabilize them. So what you have is your 027 TMA. This is an 036 sheath, just welded onto the bottom side of the expander. Okay, we recurve this. You don't tighten it up. TMA, it will fracture very easily. And recurve it, and then make a real sharp outward bend. So when you put this in, it's pretty rigid, but it's not, like fitting an 036 recurved into an 036 sheath. And you got your little distalizer here. The whole appliance goes in mass. And we strap up the upper arch right away. So the day that I place the appliance, what we're going to do is strap up the upper arch. I'm going to put an arch wire in here for the anchorage of the upper arch, and we'll distalize. This is at 10 weeks, so this is about 2.5 months. Okay. We're not looking for a great deal of distalization here, maybe 3-4 millimeters. The key with these appliances is the anchorage that you use afterwards to hold them. There's no question you can get the molars back into a nice overcorrected class 1. What happens after that? See? So we put a little arch wire in. Interestingly, if you're expanding, when you put the arch wire in, and I'll put in like a round wire, an Australian wire, you don't want to put an expensive arch wire in at this particular point. The arch wire will go from the distal to the bicuspid around to the midline, right here. You want to stop it at the midline, why? We're expanding. See, we're moving 2 bones out. So we want to bring them out. You've got the stability, but you're going to get your opening at the midline, move the 2 arches apart, and then after we finish with that and tie this off, then I'll maybe put in a continuous arch wire. And just go from bicuspid to bicuspid and let the upper molars just go on back. Now, at this point, the key, again, is anchorage. And what a lot of people like to do is they like to put a continuous arch in, and they'll start putting elastic chain along the buccal segment and dragging these teeth along an arch wire. Well, it's just, unbelievable friction. Don't be surprised if your upper molars are back in a class 2 again by the time you finish with that. What we found is that it's just much easier to go through a process we call free floating. In other words, we're not even concerned about the alignment or the rotations of these teeth at this particular point. All I want is this segment back in a good solid class 1. The leveling will take place later on. So we're overcorrected back here. What I will do is just ligate these 3 teeth together, and then we'll put a elastic chain in here. There is no arch wire in here at all. Okay? What's holding the upper molars at this time is an upper utility arch. So this arch will come back, and it's butted against the upper first molars. Okay? And it also uses a collection point for class 2 elastics, because now is when we're going to use our class 2 elastics. We're not going to wait till the very end and work and work and work. We're going to use our class 2 elastics right now when they're of great value. Steve Tracy and I are talking about there's some appliances called bite jumpers. This is a great time to use Jasper jumpers or bite jumpers, bite fixers, to put them in, to tie them in and put them in and then retract against that. It uses very little anchorage because you're just free floating the teeth, not sliding them along the wire. So just draw these back, and you can see a chain here. If we've got quite a distance we're moving, and I think this is probably a little bit more overcorrected than we really need, I'll leave a couple loops in here. I'll use a light elastic thread and twist it so it's a real gentle force retracting these teeth. This is going to happen real fast. So you can see the overcorrection in the buccal segment. You're all the way back into a little overcorrected, almost a class 3 here. These 3 teeth are tied together, elastic chain. Take it back into a nice, solid, overcorrected class 1. What that's going to do is take the space that you have created back here and move it to the mesial of the upper cuspid. All right? Still not, we don't have tip backs in here. We're not trying to open the bite at this particular point. All we're doing is using this as a catch point for class 2 elastics. It's a 16 square azuloy. Ligated together. The 3 teeth are ligated together. Then, at this point, once the retraction is completed, now there's a step that's missing in here. Normally, once you've finished that, you want to go in and you want to take some time and level the upper arch. You're in a good, solid, overcorrected class 1. You've got a space mesial to the upper cuspids. Now, settle down with things. You're leveling the lower arch. All right? Go ahead and take some time. Normally, I'll have the patient in a leveling arch up above for 2 or 3 months to get all of the alignment and rotations out of the upper arch. Then we come back and pick up the upper incisors and retract them. This is at 20 through 28 weeks.
Do you level? Do you use an overlay first? Or?
No, I don't use any overlays at all. I just go straight to a typical leveling arch. If I can get in, you want to use the cheapest arch wire you can. So I'll use a 014 Australian if that'll do the job. An 014 nitinol. A great wire to start putting some torque control in is an 017 by 017 copper nitai. See? So whatever you need to work that out. You'll have a little bit of tipping. You might have a little bit of rotation of the teeth free floating, but you'd be surprised how far you can take them without much. I mean, you get them back, you put a leveling arch in, and you can free float these teeth back without a whole lot of tipping, 5, 6, 7 millimeters. It'll surprise you. You almost have to try it to see it and to believe it. So, at this point now we're going to come back and we're going to use our TMA closing arch. Now, this is a very, very clear here that obviously I cannot retract these incisors at this particular point. All you're going to do is jam the lower arch. I mean, you'd be surprised. I spent a lot of time with the students. You'd be surprised how they will take an arch, and there's no thought about this thing about overbite and overjet control, and just start closing it. And you'll get the patients coming in, and the mandibles being set back, and the patient starting to click. All you're doing is jamming these upper incisors against the lower. You've got to have this overbite and torque control as you're doing the closing process. So if this in at this particular point, we're going to start to extrude here. We've activated the loop to close here. I'll typically support this if we need it at this point with some class 2 elastics. If you've overcorrected it this much, you really don't need much at all. You really don't need elastics at all. So intruding, extruding, and closing space. Here we are, maybe 6 to 8 weeks down the road. What you've done is close the space, brought it up to an edge-to-edge overbite. You've got a step up between your canines and your laterals, all right? So we'll finish closing space here. Actually, this little gal is so overcorrected here that we can't even take her back any further at this particular point. So what do you do? How do you finish this? The best way to finish most cases is to have one base arch, a rigid ideal arch. Usually I'll use the lower arch as the rigid arch. So that's going to be my base arch. My ideal arch is a TMA. I never use stainless steel in any of these cases at all. TMA is a great wire because you can put a reverse curve in it. If you have to re-bracket, it has some flexion so you can engage them back in the brackets again. Why go to a stainless steel if you don't need it? So we have a TMA on the lower, retract it, and we want to use a flexion arch. You want to use a very flexible wire to seat the upper incisors back down over the lower. Common arch wire for us is a 016 by 022 force 9. This is an 8 braided wire. It's just like a buttery wire that you can wear vertical elastics against to start to reseat the incisors. If I need to maintain some step up in it, what's great about this wire is you can make first order bends in it. You need to set the laterals in, set the cuspids out. It's an 8 braided wire that maintains torque control, is flexible, and yet you can bend. You can make first order bends in. From a practical standpoint, use the least expensive wire to do the job. So at this point of coming back and re-engaging it as an 012 stainless steel, that's the wire that you use. And at this point we start to re-engage with triangular elastics. Or quite often I'll use what are called short triangular elastics. They're an elastic that goes up, over, and down. It's a little bit tighter. Patients don't wear their rubber bands anyway, so I'll have a little bit to... Someone told me the other day, he said, you know, I use headgears, but my patients don't. I use rubber bands, but my patients don't. And again, just letting this work itself out to re-engage. I don't show it here, but when I guess I do. The key to this is to tie the cuspid to cuspid together. So we ligate these 6 teeth together, so as we're re-engaging the incisors, we don't reopen space. So when we get to this point, get into a flexion wire, ligate the teeth together, get your short triangular elastics going. This will seat the buccal segments, seat the incisors, and you're out of there. This mechanics, I mean, obviously this is a very compliant little girl. She brushed her teeth. She would do it. I mean, if you asked her to wear a headgear, she would have worn a headgear. But a case like this where you have a compliant child, you can just absolutely blow away. And, you know, not that even time is that important, but, you know, at 9 months to a year, you're trying to figure out what to do, you know, with the rest of your time. Sometimes I use a little box elastic. I like to use like what's called a short box. So it would be a little box elastic that would come over the incisors. I like it because it doesn't get down on the tissue around the lower incisors. It's a little bit tighter, so it goes from here over the brackets and down just to re-engage the incisors. We've intruded, torqued, seated the buccal segments. Now we want to bring everything back home again. And she finished at 52 weeks. Then the other thing you want to do is if you're using non-compliant techniques, you want to use it in your retention also. So we've gone almost exclusively to permanent retention. what I like, there's a wire made by Reliance called Bond-A-Braid. It's an 8-braided wire. Remember, when you bond teeth together, you can't use round wires. They'll allow torque to occur. If you use just a plain round wire, what will happen is it'll twist within the bonding, so you'll get some torquing going on. If you use a braided round wire, there's a very, very slight memory in the wire to take the teeth and twist them. So given 2 or 3 years, you'll start to see these strange things happening with a bonded braided wire. Look at the way the wire twists. It's the same way that the teeth are going. Sometimes you can see your lower cuspids start to roll inside. It's just torque control because it's held within the bonding medium. This is a braided wire, so you have torque control when you put it on. It's dead soft. It's blade thin. It's been run through a roller, so it's blade thin. We pull it up against the teeth with some dental floss and then bond it on. I bond it through the labial. Have the patient bite down and then cure it through the labial so you don't have any interferences, and leave it on. It stays on for years. And then we use an 027 TMA on the lower, and I'll leave that on as long as the patient will let me keep it in there. This is a strange one because it has flexion on it. In other words, when you come in, you can take this with a plugger and push it all the way down to the gingiva, and it'll come all the way back up again. So one of the things that happens with rigid wires is that if you bite a piece of ice or something rigid, you bend the wire, and then the teeth go with it. This has flexion and allows this to move around. I don't bond it to every tooth because of cleanliness. Like every once in a while, I'll use this on the lower for bonding if I have a lot of rotations. But if I've got good integrity to the lower arch, we just put this in and leave it in. And that's the retention. We put this on the day that we take the appliances off. The only thing that I would add to that is that if you've had expansion, a lot of expansion in the upper arch, and you're worried about maxillary constriction, what I'll do is put all this stuff on and just do a sunk-down overlay over the top of it that the patient will wear at night or every other night. And that's the retention pro forma. Go to something like this, and you can watch your lab bill drop about $1,800 a month. It's amazing. So, non-compliance and retention also. We use Enlight, and then Enlight sealant. We go in and keep it dry and that sort of thing. All of our other bonding is done with Enlight, and it's wet field bonding, so the teeth are wet, and when we put the medium on to bond them. Okay, I've used up my 20 minutes. Any questions?